Thanks for having me. I'm going to be talking to you guys briefly about recurrent acute sinusitis. This is a picture of Madigan where I'm going to be working for about the next month or so. It's an old picture because you can see here there's no parking lot yet and there's no lawn. So about 25 years old. So about a decade ago, we started to have interest in a different entity. So a little bit different from ARS in that these folks weren't just having like 1 or 2 acute infections a year, and different from CRS because they were, these people were asymptomatic in between their episodes. So these folks were having 4 or more episodes of purulent rhinorrhea per year, and in between, they felt just fine. So we know now that it affects about 1 in 3,000 people at a cost of about $1,000 per patient per year. And the reason for that, we think, is partly because there's a delay in diagnosis. A lot of people are not getting an early CT scan or endoscopy, and so they're just getting their antibiotics, walking out the door, and then they're getting sick again. But we do know that they have issues with lost work and productivity on par with CRS. There's also thought to be some physiologic contributing factors. We know that the average adult gets 2 to 3 viral infections per year, and we think that may be contributing, as well as mucosal edema from allergic rhinitis or immunologic deficiency playing a role as well. So what about anatomic factors? Well, we think that there's a couple of studies out there that agree that Haller cells seem to have an effect by narrowing the infundibular width, also potentially contrabulosa by doing the same thing, or accessory ostia. But there was a conflicting study in 2016 which came out saying that there was really no correlation between the anatomic variants that they identified. So this is a patient in my practice who identified as having recurrent acute, and you look at the image on the left and you see that he's got a little bit of frontal sinusitis, not terribly impressive, but he was draining pus. And then you look on the other side, on here on the right, and he's fine. So you treat him, he does well, and then about a month and a half later, he starts draining pus again. So this guy we actually just operated on last week. So the diagnostic criteria includes purulent nasal discharge, along with congestion, pain, pressure, or hyposmia. They have to have at least 4 discrete episodes in a year, and then again with CT or endoscopic evidence, and they should be asymptomatic in between with their infections clearing. So the CT findings, they're typically not all that impressive. You're typically going to see something more along the lines of the upper picture, where you just have a little bit of mucosal thickening in the maxillary sinus rather than a pansinusitis picture that you see on the bottom there. You can see some cell variants. There's a contrabulosa up above, but then again, what is the significance? We're not quite sure yet. When you work these patients up, it's really important to perform nasal endoscopy. Okay, not only does it get you extra RVUs, but you can document presence of purulence and then get a culture as well. And so culture-directed therapy is sort of the way that I go with these folks. Again, the CT is really important as well because it can document the affected sinuses, so you have a surgical target if you take them to surgery. It's really important to distinguish between the patients with acute rhinosinusitis, CRS, and recurrent, because the people with recurrent acute, they have worse quality of life than people with just acute rhinosinusitis. So you want to make sure that you're addressing their issues. My policy is just to have them walk in when they're sick. If they have anything like that you think is like an allergy issue or an immune issue, I refer them out as well. So I treat the acute episodes with culture-directed antibiotics, although the AAO and the ARS also say that Augmentin is okay. I add an oral or topical steroid and then allergy treatment as indicated. So the first publication addressing surgery in this subset of patients came out about a decade ago. They had all failed conservative management with antibiotics, steroids, and antihistamines. And what they all had was MMAs and anterior ethmoids at a minimum, with the other sinuses being treated as indicated. And what you can see on the upper box is that they have, in their symptom scores, they improved across the board. In terms of the medications used after surgery, they went down in the number of antihistamines used, and then number of workdays missed and number of acute infections also went down as well. They still had a level of antibiotics used that didn't reach statistical significance. The OHSU experience in 2008, they compared a subset of folks with recurrent acute with people with CRS, and they found they were less likely to have asthma, more likely to be primary surgery, but they did have quality of life improvement in both groups, although the CRS folks had better endoscopy scores. This study came out in 2015, I believe, out of Stanford. They tailored the surgery to the affected sinuses. This was a crossover study, and almost everybody got MMAs, but the more complete surgery was less and less frequent, and all groups got better, although to a larger extent in the surgical and crossover groups. Medication usage. So looking at the studies, Neil Bhattacharya's group had less antihistamine used, and there was trends in other categories like antibiotics. The OHSU group had less sinus-specific medications used following surgery, and the one last year was fewer antibiotics and decongestant. So these patients are getting benefit. In terms of productivity data, the first slide is basically just comparing a recurrent acute sinusitis group with a CRS without nasal polyposis group, and this is just showing that except for antihistamines, they're very similar in terms of their use of medications and their lost productivity. If you look at the top box in the next slide, though, what you'll see is that the recurrent acute folks, they had less antibiotic use, they had fewer decongestant use, and lost productivity days, trended but didn't quite reach statistical significance like it did for folks with CRS without nasal polyposis. So when do you operate? There was a model that was simulating about 1 to 3 years after surgery and taking into account the cost of antibiotics, cost of visits to the physician with surgery, and then the recovery. And they found that the break-even point was about 4 episodes per year. The authors suggested 6 episodes to account for viral episodes. My personal threshold is 4 just because I found that most of my patients are not patient enough to wait out 6 episodes of purulent sinusitis. So importantly, suspect the condition with multiple discrete episodes, use antibiotics, and add an oral or nasal steroid, and then my threshold is 4. But it's important to take into account the patient's motivation and lifestyle because a lot of times they're not going to necessarily want to wait. Okay? Whew, thanks.